My name is Dr. Eugene Tuishime. I'm Assistant Program Director for Research in the Anesthesia Residence Program at the University of Rwanda. I'm happy to be part of this program. The title of my talk is Introduction to Global Health and Equitable Partnerships. By the end of this presentation, I hope that everyone will be able to understand the considerations that make global health partnership equitable and representative for all partners. Also, you should be able to apply best practices in designing equitable global health partnerships. Before we jump in, let me share a little bit about Rwanda. Rwanda is a small country located in East Africa, and it is well known for hosting international conferences and also to be a good destination for tourism with availability of gorilla tracking. It is also a good destination for a good sport event, as you can see the Kigali Golf Club. It has, on top of that, a good universities like the University of Global Health Equity, and I was privileged to do a master's in global health in this university. What is global health? Global health may be defined as an area for study, research, and practice that places a priority on improving health and achieving health equity for all people worldwide. We may also think about it as a collaborative transnational research and action for promotion of health for all. However, we have to think about its colonial roots. It used to be tropical medicine and then international health, which had the agenda for high-income countries. So why global health partnerships are important, especially for anesthesiologists? First, there is disparity in perioperative outcomes globally. Second, there is severe shortage of staff in low-income countries. Third, there is inadequate funding, leading to poor working conditions in those settings. We have also to think about solidarity and social responsibility, and also that shortage of physician anesthesiologists is also happening in high-income countries. On top of that, we are seeing more diverse patient population requiring more global and cultural considerations. Let's start with the example of disparity in outcomes. I will give an example of maternal health. If we see about the maternal deaths, which happened in 2020, we can see that about 287,000 maternal deaths occurred globally. And among those, 95% happened in low and middle income countries, and Sub-Saharan Africa had 70% of all of those deaths. And the one country, Nigeria, had about 28%. This is in comparison to 5% for high-income countries. We can give us an example of Rwanda, which has a maternal mortality rate of 203 per 100,000 population in a comparison to 9 per 100,000 population for Canada. This is about 20 times more. If we look on the outcomes about obstetric anesthesia, we can see that the death for obstetric after obstetric anesthesia is very high, 0.2 per 1,000 people. This is almost very low, almost zero. In high-income countries, we can see that it ranges about 3.8 to 6.5 per million people. What about the shortage of staff? So if we look globally, we have an average of about 6.6 per 100,000 population of physician anesthesiologists. However, Sub-Saharan Africa, the majority of it has less than 1 per 100,000 population, and the whole continent has about 5,000 physician anesthesiologists, and half of them are just located in one country, South Africa. There is also inadequate funding. If we look on the total global spending, which is around 8 trillion US dollars, which is spent on health, this is about 80% of the global GDP. However, the US alone is spending 41% of the total spending, and all high-income countries combined they are spending about 80% of the spending. However, low-income countries has the spending capabilities of 0.4%, despite having 10% of the population. And the majority of Africa, sub-Saharan Africa, has less than $118 per capita spending in comparison to up to 15,000 in high-income countries like the US. We have also to consider that anesthesia and surgery in global health, they are very underfunded. So you can say that you can't even see the name of anesthesia or surgery in spending or funding for global health. So you can see that most of diseases which are funded include infectious diseases like HIV, TB, and malaria, and the non-communicable diseases. And who are the major players who are providing the funding or aid in global health? So we can see that the US government and the other high-income countries in the Western world are the major donors for global health. And on top of that, you can find international organizations such as the WHO and the UN organizations such as UNICEF and big international NGOs like the Gates Foundation. So these are the people we have to convince if we are going to get anesthesia and surgery funded. So in the context of Rwanda, we are trying to shift from aid to investment. I have a few examples of some investment which have been made in the last few years. As you can see, there's an ongoing project called 4x4 reform, which is used about 350 million US dollars to increase the number of healthcare professionals in the country by 4 times in the next 4 to 8 years. And this will include also capacity building and infrastructure and equipment improvement, and to provide world-class health services. You can look in the middle, the Biotech Rwanda initiative, which also invested about 150 million US dollars to provide the capabilities for mRNA vaccine manufacturing plant in Rwanda. And lastly, the other example is a minimally invasive surgery training center, which is a partnership between Rwanda and France. Now that we have an idea about global health, why should we be involved? So there are multiple reasons we should be involved in global health. And first, there's a need for advocacy for access to healthcare for the most vulnerable and marginalized population. And if we believe that health is a human right, then we should be involved in global health. And if we look on the US government reason to be involved in global health, they say is that they want to secure protection against global health threats for its population and to promote productivity and economic growth in other countries. We may also think about good health and good partnerships as forms of diplomacy leading to peace and prosperity. And I would like to conclude this section about why we should be involved by this quote from Paul Farmer, who said that if access to healthcare is considered human right, who is considered human enough to have that right? We have to think about that. So now, if you're convinced to be involved in global health, what kind of activities as an anesthesiologist you can do? So you can do direct clinical care, you can do teaching, you can do research and quality improvement, you can be involved in grant writing, leadership, advocacy, and mentorship. If you need to explore more about global health initiatives, you can read this book, which is explaining the role of anesthesiologists in global health. I wanted also to share my own experience in global health. So I have been involved in organizing different training programs through the Initiative for Medical Equity and Global Health, and partnering with different organizations including Stanford University, CASIF, VAST, WFSA, and other NGOs. So where we have conducted different resuscitation courses, as you see on the left. I have been involved in writing advocacy document and publications, conducting research like this resuscitation training program using both technical and non-technical skills. I was also privileged to co-chair the standards of anesthesia practice in Rwanda, and I have implemented different quality improvement programs. Now let's move on to equitable global health partnerships. How can we make these partnerships equitable? So we define equitable partnerships as mutually beneficial and power-balanced partnerships and processes leading to equitable human and environmental health outcomes. And on the left, we can see that there are good values we have to think about: fairness, respect, care, and honesty. And in the process, we have to be working together throughout the process, including co-creation of the solution, good communication, commitment for sustainability, and continuous review for improvement. And we have on the right the tool which we can use for negotiation, but also to monitor our progress, which is called the Equitable Tool for Valuing Global Partnerships, which has 4 domains, including governance and process, procedures and operations, progress and impact, and power and inclusion. So I know that I have shared this paper. I hope that you have reviewed the paper in detail. So before we go in details about how to make this partnership equitable, we have to think about the causes of inequity in global health. First, there is historical legacies of colonialism, racism, and neoliberalism, which are putting people in low-income countries at a disadvantaged position. There is also economic disparities with imbalanced financial control between high-income countries and low-income countries. There's difference in technological capabilities, funding distribution, governance structures, power dynamics, all of these giving more power to partners from high-income countries. There is also cultural differences to think about, which may lead to ineffective communication and decrease the progress on the project we're working on. Lastly, there is a problem to think about the sustainability of the collaborations. So what are the focus areas we should think about as we are considering to start or promote equitable partnerships? First, I think it's important to think about local health priorities, and we can do this by having or promoting local ownership. So we have to think about research agreement. If we are doing a research project, for example, we have to build trust, and we have to build the capacity, the local capacity to do the project and provide enough funding. And once the project is implemented, make sure everyone is involved, especially the local teams, and share the benefits from the project, and also give credit to everyone's contribution. And also, for example, the authorship is a big topic where we have to make sure that local teams have good position in the authorship to minimize the parachute research, where just you put the local teams in between authors without really valuable position like first and the last author. Now let's think about this fictional story to see what are the areas of improvement we can think of as we are renewing the partnership between the anesthesia department at the University of Ottawa and the anesthesia residence program at the University of Rwanda. For students at Stanford University, consider yourself as the members of the department at the University of Ottawa. The rest of the participants, let's consider ourselves as members of the department at the anesthesia residence program in Rwanda. So for the last 5 years, both departments have published 20 papers in peer-reviewed journals, with 5 publications by a Rwandan first or last author. They have also secured 100,000 US dollars in grant funding, graduated 30 Rwandan residents, and among 10 Rwandan faculty, and have been promoted to associate professor in comparison to 4 faculty from the University of Ottawa. 2 Rwandan faculty and 4 residents have visited Ottawa for 2 months elective, in comparison to 10 faculty and 15 residents from the University of Ottawa. The major decisions were made by the PI from the University of Ottawa because the grant was under his name. No research compensation was given to the UR faculty, as they all have a monthly salary, so they decided there was no need to pay them twice. But the PI hired research assistant for them and a statistician in Canada and organized funded workshop. Think about 3 areas of improvement and put your answers in the chat. I will give you 30 seconds. I hope that you are posting your answers. So how would I approach this? So first, for the overall assessment of this partnership, I will just use the Equitable tool for varying global partnerships we have discussed about, which has 4 domains again and 54 questions. And among them, I will find key 3 questions to raise as a discussion point in our meeting. I will think about these 4 domains, including governance or process, procedures and operations, progress and impact of our partnership, and power and inclusion. Also, I will think about the strategic leadership of our partnership. At which level are we as we progress towards equity and the sustainability of the program? So as you can see, there are a few aspects of the partnership to think about. Are we at transactional level where we just have the respect? We have a good data and evidence of what we do. We have transparency. We have power management strategies. We have the resources and the expertise we need, and we have good governance. But still, everyone is working towards improving the organizational benefits in comparison to the social good. Or we're at a collaborative level where we have achieved the trust, a deep understanding, relationship, and also we have shared vision, and we are moving towards really the societal good. Or are we at the best level possible, which is transformational level, where we have achieved equity, our programs are promoting societal good over the organizational and individual benefits. The other way I will think about it also, I'll go in details about ongoing research project and use this checklist provided by Hodgson and colleagues, which has about 20 questions focusing on the process of research process, including the design phase, the implementation phase, and the analysis and dissemination phase, where you have to make sure that both local and international teams are involved at the same level. The funding is shared equitably, decision-making is shared among the team members, and also the benefit of the program is shared among all members, especially with authorship and also capacity building for sustainability. So my take-home message from this introduction to global health is that you need formal global health training in order to build successful global health partnership. Also, I think that to have reliable teams and equitable partnerships may lead to successful project. Lastly, local ownership is essential for sustainability. So thank you very much for your kind attention. If you have any question, you can send the question to my email. Also, you can check our website for our global health work, and I'm happy to take any questions.